The TMJ-TMD conundrum is real and has been puzzling the dental and medical professions for decades. This is the TMJ-TMD Demystified podcast with Dr. Tony Urbanek, where we'll connect the dots between TMD symptoms and the actual cause. We'll tackle common TMD misconceptions and educate you, the practitioner, about a simple, tested, and proven TMD solution that has already provided relief to thousands of patients, while helping practitioners build an additional source of income free from insurance control. Welcome to this episode of the TMJ-TMD Demystified podcast.
Welcome, TMD warriors. We are gathered here today for the next episode of TMD Demystified. I am Tony Urbanek, and today I am going to kind of go out on the limb a little bit and discuss the general nature of the patient's perception, the doctor's perception, the interplay between doctor and patient, and the professions regarding TMD. The title of today's episode is going to be Hope, Persuasion, Fact, Fiction, Fear, Trust, and TMD. I don't know how many of those concepts we're going to actually be able to cover in the next 30 minutes. Frankly, I am not sure exactly what I'm going to say. But each one of those concepts as it relates to TMD definitely comes into play when a provider, a doctor, as myself or someone else who wants to treat temporomandibular joint problems or wants to know how to treat temporomandibular problems, needs to factor in those concepts. Before we get into that, I want to make a little description or comment about why I'm going to do this episode today, because the last two episodes I copied were very technical in nature, and they didn't get many people opening them, because I track how the episode goes and how many people view the episode. And although I wasn't disappointed, I mean, if nobody watches it, that's okay with me. One of the reasons that I'm doing this is not only to teach and to emphasize and to stimulate, but a very good reason is to document what I've discovered, document what I found, and for the future, whoever wants to look at it. Obviously, it cuts both ways. Sometimes in the future, as we all know, that you document things and now everything is on the internet and it stays forever, and you might run across something that you wish you didn't say, or you wish you didn't say it exactly that way. That's always an opportunity and a possibility, and of course I'm ready for that, but I think it's important to document what I've discovered in treating now approaching 4,000 patients with a patented device that actually works. And I stand by that 100% for the future, because of the mysticism that has gone on about TMD for so long, my entire career. And my attempt to straighten this out is my attempt, right or wrong. But I invite any and all who want to bring any other facts to my attention, or bring any other point of view to my attention that they can back up with facts. I want to hear about it. I want to listen. And I'm hoping that anyone, whether you have another point of view or whether you know nothing about this, or you're here to learn, or even if you're a patient who wants to learn, that you view these episodes with what usually is called an open mind, which is important, but I would prefer to use the concept of critical thinking rather than open mind, because sometimes you open your mind and it's aberrated by different thoughts or feelings or information. So when you gather information, it's all about, as I've been taught, and I practice, critical thinking. And I'll let you look up critical thinking on the concept and how you do that yourself. So when it comes to today's topic, we're not going to be technical in nature. This is kind of fluffy. This is the kind of thing that actually you have to deal with as a patient, as a provider, as an interplay between a patient and provider on the topic of TMD. And the problem is that there traditionally and historically been so much confusion and frankly nonsense, and we're going to talk about some nonsense that has gone on about TMD and continues to go on about TMD, about beliefs and treatments and concerns that is across the board pandemic. So for a very quick review, this is going to be the 73rd episode, and if you want to review all the specifics, you can go to many of your episodes, but for a quick review, it's all about inflammation in the joint. If you can make inflammation as a provider, or if you can figure out a way as a patient to make this inflammation to go away for a long period of time, considerable long period of time, you have solved the problems, because you will make those symptoms go away of TMD. Symptoms being frequent or recurring headache, earache, jaw pain, neck pain, tinnitus, ringing in the ears, subjective hearing loss, fullness in the ears, vertigo, upper back and shoulder pain or tightness, arm, hand, finger tingling and numbness, and various kinds of locking. Those are the well-known accepted TMD symptoms. There are a few others that I can talk on that are not unaccepted, but they're not as common. But those are the common symptoms of TMD. And if you make the inflammation diminish, go away consistently, long enough, persistently, I guess persistently is the right word, all those symptoms subside and go away, and they stay away. So if you unload the joint long enough, that will happen. Now let's get into this topic that I want to talk about today, because I've mentioned this many times before, but I try vividly not to show my frustration with the system, with the medical system, the dental system that for 50, 60 years has been a proponent of treating TMD in many ways that are not effective. The best example I know of is surgically, and that's why 11 years ago now I gave up surgery as a customary treatment for temporomandibular joint disorder, because I vividly saw over many, many years and 2,000 cases of TMD treated surgically that surgery really was not the answer. But there are a lot of other things that have been proposed and actually done that are not the answer that's currently going on. So currently the scene is the establishment, dental establishment, medical establishment continues to use, to a lesser degree, surgery, no doubt about it. You can hardly find an oral and maxillofacial surgeon who wants to do surgery for the temporomandibular joint problems, becoming less and less. But also non-surgical treatment, which I've talked about in many cases, which include drugs and physical therapy and myofascial therapy and dry needling, and of course Botox, which I just did a episode on, that are not any better than surgery, and sometimes worse, because some of those things have rather significant side effects and deleterious effects. But again, that isn't the topic for today. We're going to talk about TMD and hope. Let's just start out with hope. Hope, persuasion, fact, fiction, fear, trust, and TMD. Patients hope that when they have these symptoms that they can go someplace, whether it be Dr. Google or their PCP or their dentist or the walk-in clinic, and when they have these symptoms come up, that they can get resolution of their symptoms. They want hope. Again, my frustration, which I try not to show, is because I see on a daily basis, and have seen on a daily basis for years and years. The patients that come in with 10, 20, 30 or more, 40 and some 50 years of symptoms that have seen multiple doctors, just going in circles between doctors, providers, ENTs, dentists, physicians, of all kinds and all persuasions, and been promised, a solution if you do this or that. And then they're sitting in my office with the same symptoms that they have for so long period of time. As a provider, that is very frustrating, and the patients have hope. Some of them just never give up, and that's good that they don't give up, because there is hope. There is a solution for this problem. And the physician has hope that what he does is actually going to be effective. But as we all know, the consensus in the United States of America and beyond is that when it comes to treating this thing that we now call TMD, that nothing works. And that's the consensus. Consensus among general dentists. It's the consensus among physicians. It is now the consensus among patients. But the patients, they still have hope. And I've had many patients say, I'm out of hope. They're sitting in my office asking for assistance, and they say, I'm out of hope. And I don't ask them, but I want to say, well, why are you here if you're out of hope? It's because the symptoms are severe. I mean, if you don't have a history of these symptoms, you have to understand that chronic pain that won't go away, that is unexplainable, is a very suppressive set of circumstances, and depressive. These patients are depressed. That is why some of my colleagues always ask me why I wanted to be, a surgeon doing temporomandibular joint surgery. But even now, I mean, why do you want to do temporomandibular joint treatment? These patients are so depressed that they're basically crazy. They're not crazy. They can be depressed because they've had these symptoms going on for years and years, and no one can even suggest a reasonable answer that is effective. So, patients need hope, and the doctors need hope. And I'm here to supply hope for the doctors and the patients. Not just, flimsy hope. I mean, what we've accomplished here is documented by and validated by a university study based on our current 3,000 successfully treated patients, now approaching 4,000. And therefore there is hope. But if you treat these patients, if you see these patients, if you know a patient who has had years of chronic TMD symptoms, they're running out of hope. And it is always good to give people hope if it's valid. And I have no problem at all giving patients hope, because I know that if they will follow the protocol and use the device, which unloads the joint, which makes the inflammation go away long enough to decrease the symptoms, that they will get relief. I know that. You don't have to believe me. You can just read our study. It's scientific, it's analytical. And we're not out here to persuade you about this. This is nothing about persuasion. I don't try to persuade patients to do our device and protocol. I just give them the facts. I give them what I know about this problem, because I have seen patients on a daily basis, whether it be surgical or non-surgical, for my entire career, which now approaches 46 years. I claim to know this problem inside out and backwards very, very well, because I have done consultations for well over 5,000 patients, most of them recently within the past 7 years. So it's not about persuasion, whether it be persuading the doctor to accept using the device and protocol, or persuading the patient that they should do the device and protocol. It's all about just giving the patient facts, which is the next item on the list. We're dealing with facts, and the fact can be, it's fact. The definition of fact is something that can be reproduced again and again, reproduced, based on if you do the same thing, the same occurrence will occur. And if that happens long enough, that makes it fact. And then if it's analyzed scientifically, statistically, which is the definition of peer review article, a statistical analysis of your study basically is the hallmark of a peer review study or article, then that becomes science. So there's a little difference between fact and science. I admit science is statistically, analytically gone over. But a fact is simply a series of events or event that can be reproduced by doing the same circumstances time and time again. So there's fact and fiction, and the rest that lies outside of fact is truly just fiction. There's hope, which patients need, and some of them have run out of hope and just live with it. And I've talked before that I've had a few patients who actually have told me that they're out of hope, and a couple of them have actually said they were considering suicide because of the chronic pain that they had no hope for. We're not out here to persuade patients or doctors as to what we found. What we found is factual, and the facts are now analytically available, statistically studied in a scientific form that's readable, and it's not fiction. So if you have that information available to you, then both the patient and the doctor should not fear, because what we fear is what is unknown. I can think of 1,000 examples. One close to my heart because I'm an aviator and been an aviator for 46 years. A lot of people fear flying in a general aviation aircraft, small aircraft, single engine, multi-engine aircraft, not an airliner. Anything other than a 150-seat airliner is a small aircraft to most people. And of course, I've been flying them for 46 years, and I don't fear them because I know not only how the aircraft operates and how the engine works, but I know all about the weather involved in flying an aircraft, and how to communicate with air traffic control, and all about navigation, which now is much simplified with GPS. And I'm not fearful of general aviation aircraft, but I have passengers at times that are very fearful, and I've seen that. And why are they fearful? Because they don't have my knowledge. If they had my knowledge about general aviation aircraft, they would not be fearful. Same thing applies to TMD. If you actually have the knowledge, then you are not going to have fear about treatment or fear about what's going on. That is why a good practitioner, if he's a smart practitioner, it isn't just saying, well, this is what I'm going to do for you, whether it be a surgical event or a pharmaceutical recommendation or a physical effect. It really needs to go well beyond that. A good practitioner, provider should explain why he's doing what he does and how it works. If you can't explain why you're doing what you're doing and how it works, you shouldn't be doing it, frankly, whether it be surgical or non-surgical, which brings me to a really good point. A lot of these practitioners out there, and I see it all the time here in Middle Tennessee, and I read on it throughout the country. It's been going on for a long time. They're recommending and doing things that they read about, that are told is helpful, but it is not. But they can't explain how it works. They can't explain to themselves how it works, let alone how it works to the patient. Therefore, they shouldn't be doing it. And if you can do that, brings us to the next point, which is trust. And this applies not just to TMD, again, because I've been a provider, surgical and non-surgical, for 46 years. I had the option to be senior with white hair and have a lot of experience. And I have found, and I recommend for anyone involved, if you want to develop trust with your patients, you need to be able to explain to them, to educate them as to exactly what you're doing, why you're doing it. And if you do that, you decrease fear and you increase trust. And that is what is greatly needed in the area of TMD. Your credentials, that brings me to another point. I mean, I have credentials. I got doctors after my name and all kind of academic training, and 2 years as a fellow with the NIH. That not even important to me. It shouldn't be really important to anybody else unless you're another doctor trying to impress another doctor. Academic credentials is really not important. And I see doctors all the time who are in the arena of treating TMD, and they think they put a lot of letters behind their name and whatever, and they think that that's going to impress patients and be a significant value to them as a doctor treating TMD. No, it's not. And no, it shouldn't be. And if it impresses some patients, I'm sorry, but it shouldn't. It's all about whether the provider can actually produce what he claims he can produce, but more importantly, explain to himself and his patients about how it works. You can't go around doing something and not actually knowing how it works. And a good example of that, I did a little preparation. I did do a little preparation for today's episode. And I wanted to talk a little bit about some stuff that I've seen and going on for years regarding myofascial therapy. Again, I started the episode talking about it's just all about inflammation in the joint. And if you can make the inflammation in the temporomandibular joint go away, the symptoms go away. But for years and years, this thing called myofascial therapy, which is defined, I actually pulled up the definition off the computer a few minutes ago. Myofascial or myofunctional therapy is the neuromuscular re-education or repatterning of the oral facial muscles. The therapy includes facial and tongue exercises and behavior modification techniques to promote proper tongue position, improved breathing, chewing, and swallowing. None of that has anything to do with decreasing inflammation within the temporomandibular joint, which causes all the symptoms. And the reason I bring that to your attention, and if I upset someone, it's not my intention to be critical or to sound overbearing in any way, shape, or form. But when you see hundreds of patients a year with this problem that have seen multiple practitioners doing some of these things that are not effective, it's frustrating to the doctor, it's frustrating to the patient, and someone needs to speak up. And that's just an example. There are many examples. Another one is dry needling into the muscles as a treatment for neck and shoulder pain. Well, if that neck and shoulder pain is coming from inflammation within the temporomandibular joint, I can tell you that it's not going to be effective. There is a theory behind dry needling. It's done primarily by physical therapists, and that is you put a dry needle into a muscle and it stimulates the muscle to relax. And it may do. It is a theory, but it may do that. But when you take the needles out, and eventually, if that muscle does relax for a while and the muscle is actually tight, pulling on the bone and creating some pain, it does not relieve inflammation in the joint. So after a relatively short period of time, and this is what I've been told by patients time and time again, is that it works for a short period of time, a few days, and then the pain returns. Why does the pain return? Because dry needling has nothing to do with releasing or decreasing inflammation within the temporomandibular joint. All these things are really obvious. So we need to actually take a look at all of these other treatments. I had an earlier episode that I entitled Poking the Bear. And the establishment is the bear, whether it's the medical establishment, dental establishment, oral and maxillofacial surgery establishment. All these establishments are very biased as to, their point of view, and everyone's welcome to their point of view. However, if you're going to have a point of view, you need to back it up with faction, not fiction. And you need to be able to bring the facts into the open that can be reproduced multiple times by multiple providers. That makes it fact, not fiction. That makes it fact, not anecdotal. And when you then analyze it statistically, then it can be peer-reviewed and makes it science. And that makes it valid. That makes it valid. I pulled up a little picture of myofascial therapy. I don't mean to be really critical, but it's a picture of, it looks like a mom and dad practicing myofascial myofascial treatment with their daughter. It is not a treatment for temporomandibular joint problems. There are many others. We talk about the drugs. We talked about the Botox. We talked about the psychiatric drugs. We talked about muscle relaxants, all of them having no long-term effect at all on temporomandibular joint problems. As kind of a further explanation, non-steroidals, Motrin, Tylenol, aspirin, the most common, work really well on inflammation. The problem is they only work for a short period of time, after which they run out of steam. You might get 2 or 3 weeks out of a non-steroidal, and then all they do is tear up your stomach. But it proves the point that non-steroidals, how they act very, very well on decreasing inflammation within the temporomandibular joint. But they're only short-term. You need a long-term decrease of the inflammation within the joint, which occurs when you unload the joint long enough to allow the inflammation to go away. That's why there's a device and protocol that goes with it. Goes with our device. Very important protocol. So I've spoken my piece for today. I'm not sure that it's going to get a lot of views, which is okay with me. What I would hope it does for those who do view it is to be cognizant that there are just a myriad of treatments for temporomandibular joint that are not effective, that when you look at them critically thinking, they hold no water. And my job, and it's my job because I've taken it as my job. It's my responsibility now because I figured out a way to make the inflammation in the joint go away long enough to make all the symptoms go away. We call it the Urbanek device and protocol. If there's anybody out there that would, any providers, dentists, oral surgeons, orthodontists, who would like to join our network of doctors, growing network of doctors who would want to provide this service for their patients, we can be contacted. I can be contacted personally at Tony@tmjservices.net. Our Director of Education and Marketing, Naomi, can be contacted at her email, Naomi@tmjservices.net. You can view much more about our company and the service we provide with our device and protocol at www.tmjservices.net. I encourage you to do that. We have a solution for this problem, and it is we're getting really good traction. We're adding numbers of dental service organizations who now think critically about this problem, look at it critically once I bring it to their attention, who are joining our network. It's very exciting. But we're a long way from getting as many providers as we need to cover the United States, Canada, and beyond. It is a big problem overcoming the concept that everyone knows when it comes to TMD, nothing works. That's the skepticism, and I'm okay that there's skepticism. All I ask you to do is think critically, look at the facts, judge for yourself, and if you're doing a treatment, you need to have the facts, be able to explain it, back it up with facts and science. So for today, I look forward to speaking with you in a week on our next topic. And I hope you have a very successful week. I know that I and my associates in the company plan on having a great week too. I'm Tony Urbanek, and this is TMD Demystified.